We're going to talk about anemia today. So when you look at a whole variety of different studies across different populations, the definition of a normal hemoglobin and hematocrit varies. And so we want to sort of think about calling a patient anemic based on the population or what population of patients that patient belongs to before we really say whether or not the hemoglobin is abnormally low. So under optimal conditions, the rate of production of our red cells equals the rate of loss. The average lifespan of a mature red blood cell in our circulation is somewhere between 110 and 120 days. And if we think about this, we want to remember these numbers, right? So it's right about 3 months, and it's right about 4 months. And we want to think about that when we're thinking about how we're correcting different forms of anemia and how long it might take to see the benefits of our therapeutic interventions. About 1% of our red cells are removed from the circulation each day. It's a normal senescence that happens in order to allow the repopulation. Our marrow produces about 50,000 reticulocytes per microliter of blood each day, and that's enough to maintain a stable red blood cell mass. However, if either one of those two things that we just talked about significantly changes, then that's going to result in anemia. So if we are removing more than that 1% of red blood cells each day related to hemolysis or blood loss, or if our production is somehow inhibited, we don't have enough iron, we don't have enough B12, or we are suppressing production with different medications, then we're going to also potentially become anemic. Our marrow does have the ability to increase the production of red blood cells in response to erythropoietin about 5-fold. So if we are having loss or destruction that is within that 5-fold realm, we can almost always compensate to a pretty decent extent. But when the loss or the hemolysis exceeds that 5-fold ability to increase production, that's when we're going to start to see a decline in our overall hemoglobin and hematocrit levels. So one of the things about red blood cells is that size and shape of them tells us a whole lot about why patients might be anemic. And so when we look at a normal peripheral blood smear, what we're looking at here is this is a normal lymphocyte, which is going to have a pretty large round nucleus, a pretty small amount of cytoplasm. These other little anucleate cells are platelets. And then, of course, the vast majority of cells that we're going to see on a peripheral blood smear are going to be the red blood cells or the erythrocytes. And gauging size of red blood cells, it's always nice to have a lymphocyte in the field. A red blood cell ought to be about 2/3 the
Sorry,
size.
Dr. Brim, sorry to interrupt. Eric, can you please mute yourself? Eric Lee.
A normal red blood cell ought to be about 2/3 the size of a lymphocyte nucleus. And so you can see that these guys are about 2/3. They're normal in size. They ought to be relatively uniform, although there is going to be some slight variation. And then we should always look for and be able to see this area of central pallor that indicates to us that the cells are circulating as a biconcave disc, which is the normal circulating resting state of a red blood cell. So what about symptoms? Symptoms of anemia are honestly less likely to be present if the anemia has developed gradually. There's a pretty good compensatory mechanism, and so people oftentimes aren't complaining if they have become anemic relatively gradually. Acute anemia will be much more symptomatic, And most of the symptoms are related to decreased oxygen delivery to tissues, because that's the main function of our red blood cells, of course, is to carry oxygen. If the blood loss is acute, then hypovolemia symptoms may also be present. So what are people going to complain about? They're going to potentially complain about exertional dyspnea. They may have dyspnea at rest. They're going to feel tired. They may feel like their pulses are somewhat bounding. They may be experiencing some palpitations. They may hear this roaring sound in their ears. They might have muscle cramps. They might complain about dizziness, especially on changing position, lethargy. And then again, if the blood loss is relatively acute, they may actually have syncopal episodes. So in kids and adults, our differential diagnoses are definitely somewhat different, right? And so as we think about adults, what are the common causes of newly diagnosed anemia? Iron deficiency, certainly in young adult women, is a very common abnormality. Also remember that iron deficiency in a population that's getting to be in their 50s and 60s, men and women, can certainly be an indicator of underlying GI pathology. Specifically, we want to think about carcinomas, right? Chronic disease or chronic inflammation, renal disease, and then you start getting into sort of less common things like folate and vitamin B12 deficiency, autoimmune hemolytic anemias. Once or twice a year, we do diagnose an adult who did not know that they had hereditary spherocytosis. We get into myelodysplastic syndromes, especially as we're getting into that 6th and 7th decade of life. Myelocystic processes refer to the infiltration of the bone marrow by other abnormal cells. Could be lymphoma, could be leukemia, could be solid tumor like breast or lung or colon cancer. And then we get also into an aplastic, pure red cell aplasia or aplastic anemia. So really 3 causes, right? We talked about that earlier. Either our capacity to produce red blood cells is somehow impaired, they're being cleared from the circulation sooner than they should be, or we're bleeding from somewhere. So decreased red cell production, lack of nutritional elements like iron, B12, or folate, dietary deficiency or malabsorption are probably the biggest ones. And then, of course, in iron deficiency, that's going to be a problem when we have chronic or acute blood loss. Primary abnormalities with how the marrow is functioning would be things like aplastic anemia, pure red cell aplasia, and both of those are immunologic phenomenon. There's myelodysplastic syndrome, as we talked about, older population, and then there can be that myelocystic process or tumor infiltration. We've got suppression of the marrow by medications, chemotherapy, or radiation. Hormonal imbalances, so decreased erythropoietin production, most commonly related to renal insufficiency. Severe hypothyroidism and hypogonadism can also cause anemia. And then anemia of chronic inflammation, the one that nobody wants to attribute anemia to, but it does occur, and we understand a lot more about the anemia of chronic inflammation today. It's characterized by a decreased availability of iron, even though iron stores are normal or increased. There's a reduction of the red cell lifespan. There's increased hepcidin and a relative decrease in erythropoietin levels. So when we look at a blood smear, the normal one again here, and then this is a patient who has a microcytic hypochromic anemia. So here's that normal lymphocyte again, there's the nucleus, and then you look at these cells, they're much smaller than 2/3 the size of that nucleus, As a matter of fact, I maybe could fit 3 or 4 inside that lymphocyte nucleus. You also see this area of central pallor is increased in a fair number of cells. That's the hypochromic part. And then in iron deficiency especially, you can see these abnormally shaped cells. So you get these cigar shapes. So a lot of different sizes and shapes is very consistent with iron deficiency. It's a disease where you're going to have the highest RDWs probably that you'll see. And remember that the relative distribution width, or the RDW on that CBC, is going to tell you the difference between the smallest cell and the largest cell. And the bigger that difference is, the more likely this is related to iron deficiency. What happens, of course, is that when there's not enough iron, the body tries to make these super small cells. If you get any iron in the system, you eat something that has iron in it, then it can make these larger cells for a short period of time. So microcytic hyperchromic anemia most commonly is going to be iron deficiency anemia, especially if you measure body iron stores by looking at TIBC, iron levels, and ferritins. If there's a normal or increased body iron store, then we have to think about impaired iron metabolism, anemia of chronic disease, defective absorption or transport of iron. And then we also get those disorders of globin synthesis, specifically the alpha thalassemias, which are going to make the cells very small. The difference between a thalassemia microcytosis and an iron deficiency microcytosis is going to be that RDW. So if you think about thalassemia as a problem with the factory, the mold is small for every single cell, as opposed to iron deficiency, where the mold is normal, but how much material we put in the mold varies every time. So that's where we get that really wide RDW, as opposed to a patient that has thalassemia will have a normal RDW. The next thing is that the cells can be large, and there's not a lymphocyte for us to compare these cells to, but they are large. And then the other abnormality when we're having a megaloblastic anemia is that there are increased number of lobes in our polys. And so this is a neutrophil that has 1, 2, 3, 4, 5, 6, 7 lobes. Anytime you see more than 6 lobes in a poly, you have to think about a megaloblastic process. So you guys all remember about cobalamin levels. There can be false positives and false negatives. So in somebody that has a low serum cobalamin in the absence of true cobalamin deficiency, it can be related to folate. It can also be related to multiple myeloma and what the protein does in the measurement of B12. You can have transcobalamin 1 deficiency, or patients can have recently gotten other radioisotopes, which can interfere with the test. In patients that have a normal B12 level in the presence of a true deficiency, we think about myeloproliferative disorders, hepatomas, some autoimmune diseases, and sometimes monocytic leukemias. And then if people have active liver disease where they're releasing B12 from their hepatocytes. So remember that folate and B12 deficiency have some similar clinical manifestations. They can both have pancytopenia with megaloblastic marrows. They can have the beefy red tongue. They can have the premature graying, and then unique to cobalamin deficiency, remember, is the posterior column abnormalities. So then what about destruction? So a lifespan of less than 100 days is the definition of hemolysis. Sorry about that. Anemia results when the marrow is unable to keep up with the need to replace more than about 5% of the red cell mass daily, which corresponds to a red cell survival of 20 days or less. So this has to be a pretty brisk hemolysis for the marrow not to be able to keep up. Some common causes of hemolytic anemia in adults. When we think about hemolysis, I like to think about extravascular versus intravascular. So in the extravascular destruction of red cells, we've got those kinds of hemolytic diseases that occur related to enzyme deficiencies. Most common, we're going to think about G6PD. Hemoglobinopathies like sickle cell and thalassemias, and then membrane abnormalities like hereditary spherocytosis. Things that are extrinsic to the red blood cell, also common that we see here for sure, are liver disease and hypersplenism. Autoimmune hemolytic anemias, warm or cold reacting to drugs, sometimes in IVIG immunoglobulin infusions. And then intravascular destruction would be microangiopathic, like DIC, TTP, or hemolytic uremic syndrome, aortic stenosis, transfusion reactions, like ABO incompatibility, and then some severe infections like Clostridium or malaria. And then we've got paroxysmal nocturnal hemoglobinuria. If for some reason we're giving patients a large amount of intravenous hypotonic solution, we can cause the red blood cells to swell and burst. And then some types of snake bites can also cause this intravascular hemolysis. So inherited hemolytic anemias like spherocytosis, sickle cell, or thalassemia, and then acquired like autoimmune hemolytic anemias or MAHA or malaria. And MAHA, remember, is microangiopathic hemolytic anemia. So when we have MAHA or microangiopathic hemolytic anemia, we're going to see a pretty classic pathognomonic finding on a peripheral blood smear. So we're going to see a reduced number of platelets. And so if we look at this, we only see that one platelet. Here's our lymphocyte. And so we're judging the size of our red blood cells. And what we see are these fragments. This is probably what people would consider to be a very classic schistocyte, or maybe this one. But what we can also see is that as these cells are traversing the circulation and they're being clipped or impacted by this fibrin stranding that's occurring related to the formation of the thrombin, you can see a variety of other changes. So before enough of the membrane gets removed so that you get a classic schistocyte, you can see these microspherocytes, which are very small, very dense. They've gotten a lot of their membrane removed. And then you can also see these little projections, I kind of call it nippling, where you can tell that this cell was being squeezed through. It's being distended in shape, hasn't quite broken off enough of it to be a schistocyte, but it's certainly not a normal red blood cell. So when I look at a smear and I'm looking for microangiopathic hemolytic anemia, I'm looking for all of these changes. Some of them are more pronounced if the microangiopathic changes are related to ADAMTS deficiency and TTP. Some of them are more pronounced if it's related to complement-mediated TMA. Some of them are more pronounced if it's a physical MAHA from a prosthetic valve or other turbulent flow. In sickle cell, we're rarely going to see a lot of these cells because they oftentimes sort of get trapped in the microcirculation. But if we look at a smear, we can sometimes see these very thin, sort of elongated cells that look like the end of a sickle, I assume, to some pathologist at some point in time. And then sometimes in sickle cell, we're also going to see some of these target cells. And then this is a slide that's looking at these spherocytes. Now remember, these aren't microspherocytes, and so this is not necessarily MAHA, but this could be an autoimmune hemolytic process. Intravascular hemolysis related to complement deposition and membrane attack complex is very difficult to see on a peripheral smear, but this is a smear, and these black arrows are pointing to something that are called ghost cells. And so these cells have holes in the membrane, and all of the intracellular contents have leaked out, so that all we see left here are the membranes. And so sometimes if you're having a brisk intravascular hemolysis, you can look at the slide and look and see if you can see any of these ghost cells. This patient also happens to have spherocytes, and so this is some form of autoimmune hemolytic anemia, probably a cold autoimmune hemolytic anemia, where complement is causing the intravascular portion of the hemolysis. So obvious bleeding should be pretty apparent to most of us. Occult bleeding is a difficult thing sometimes to figure out, but in men especially, and postmenopausal women who are iron deficient, we have to always think about occult bleeding. And then, occasionally there are patients who are inducing their own bleeding issues. So how are we going to think about these patients? How are we going to evaluate them? I think it's important to remember that a good history will tell us a lot, right? How long have they been symptomatic? What coexisting conditions do they have? With regards to inherited hemoglobinopathies, ethnicity is important to understand. Medications are important. Alcohol is a direct bone marrow suppressant, and so alcohol use is important. I can tell you that I have evaluated at least one patient a week during the pandemic who has become mildly anemic due to some increased enjoyment of alcohol during the pandemic. We also want to remember to ask nutritional questions, right? What is your diet? Are you a strict vegetarian? Are you vegan? Etc. Physical exam, looking for signs and symptoms, right? Tachycardia, pallor. Jaundice is going to tell us if there's hemolysis going on. We certainly want to look for splenomegaly. We want to look for hepatomegaly. We want to look for lymphadenopathy. Bone tenderness can be a clue that the marrow is infiltrated by something. If the marrow is markedly infiltrated, patients may have tenderness in their long bones and maybe along their spine. We need a CBC. We want to look at not only the hemoglobin and the hematocrit, but we want to also take that in evaluation with the white blood cell count number and the platelet count number, because if those are abnormal, that's going to change our differential diagnosis. We want to look at the MCV. Are the cells small? Are they normal size? Are they large? And then we also want to look at the RDW. What is the splay of the sizes of those cells? I think a reticulocyte count is always important. It tells us how hard is the marrow working. Is it able to compensate for this anemia? If there's an adequate reticulocyte count for the degree of anemia, then we have a pretty good idea that the marrow is working normally. If the reticulocyte count is low for the degree of anemia, we have to start thinking about whether or not there's an erythropoietin problem or an underlying marrow issue. And then, as we saw, looking at the smear, especially for hematologists, is really important. It really helps give us a lot of clues as to what the etiology of the anemia might be. So red cell indices are important. The mean corpuscular volume is a measurement of the red cell size. Normal is anywhere from 80 to 96. It's an average. So remember that if you've got a lot of really small cells and a lot of really large cells, the average can look normal. And that's when we have to look at the RDW for even more help. So microcytic indices include iron deficiency, anemia of chronic disease, copper deficiency, lead poisoning, thalassemias, other hemoglobinopathies, and some sideroblastic anemias. If the MCV is high, then reticulocytosis. So reticulocytes are larger than normal red blood cells. And if somebody's acutely recovering from a blood loss anemia, their MCV may be high. If they're chronically having a high reticulocyte count from hemolysis, their MCV might be high. Folate or B12 deficiency, of course. Remember that medications that interfere with nucleic acid synthesis, like hydroxyurea, AZT, etc., will affect the MCV. Myelodysplastic syndromes, alcohol, liver disease, and hypothyroidism. So another table, which you guys can refer to, but thinking about MCVs, very helpful in sort of making a differential diagnosis. And then you can even further subdivide into that normal RDW or an elevated RDW, right? And so a normal MCV with a normal RDW is going to be acute blood loss, anemia of chronic disease, anemia of renal disease. An elevated RDW is going to be early iron, folate, or B12. It's going to be a dimorphic anemia, iron and folate, iron and B12, chronic liver disease, myelodysplasia. So this really helps us to be able to hone in on that differential diagnosis. So a high retic count indicates an increased erythropoietic response to either hemolysis or blood loss, and a low retic count suggests deficient production. We can't look at this number in isolation, though. It has to be looked at in conjunction with the degree of anemia. Is the reticulocyte response appropriate for the degree of anemia? So you have to look at both of those things together. Same as erythropoietin levels. Is the erythropoietin response appropriate for the degree of anemia? So if somebody comes in with a hemoglobin of 8 and an erythropoietin of 20, which is technically normal, it's not appropriately elevated. So if you have a hemoglobin of 8, your EPO level should be high, not normal. And so you have an inappropriate erythropoietin response. All right, so if we look at retic counts and red blood cell parameters for diagnoses, right, we can see that if we have a corrected reticulocyte count that is low, we have one list of differentials. If we have a corrected reticulocyte count that is higher, then we have another list of differentials depending on whether our cells are small, normal, or large. Again, very helpful to try to as best as we can, make a differential based on the size of the cells, the RDW, and whether the reticulocyte response is normal or not normal. So when we look at a smear, you notice that none of the red blood cells that I showed you had a nucleus. And so if we see nucleated red blood cells in the peripheral blood, that's something that we have to think about. It's indicative of a rapid red cell turnover or a compensation for a recent anemia, or as part of a leukoerythroblastic picture, marrow is infiltrated by something abnormal that's pushing out those red blood cells before they have had a chance to get rid of their nucleus. And so if I see nucleated red blood cells on a peripheral smear, that's usually a reason to sort of think a little bit harder about what's going on with that person's marrow. And then, of course, we talked about the schistocytes. We talked about the spherocytes. Bite cells are very pathognomonic for G6PD deficiency. And then when we see a lot of these teardrop cells, it too means that the red cells are trying to squeeze out in between a marrow that's packed with something. Too many cells, fibrosis, or abnormal cells. So generally doing a bone marrow for an isolated anemia, so not if there are white cell abnormalities, not if there are platelet abnormalities, but for isolated anemia, offers little additional information in most common forms. What are the indications to think about doing a bone marrow? Well, certainly if we have an abnormality in white cells and platelets to go along with the anemia. And then if we look at the peripheral smear and we see abnormal cells on the peripheral smear, whether they be abnormal looking white cells, whether they be nucleated red blood cells, those might be reasons to think about doing a bone marrow on someone to get a better idea of what's going on. But just for anemia, we can do all the things we just talked about. We can make our differential based on the size of the cells, the RDW, the reticulocyte count, and then we can explore further whether we need to do hemoglobin electrophoresis to look for hemoglobinopathies, whether we're ordering iron, B12 folate, whether we're ordering direct antiglobulin testing to evaluate for hemolytic anemias. So it's really more about things that we do in the periphery than in the actual bone marrow exam for isolated anemias. Another table I think is helpful when we look again at size of the red blood cells and then combining that with reticulocyte evaluations, then we can come up with these differential diagnoses. So just a little bit about iron homeostasis. Average iron content in men, 35 to 45 milligrams per kilogram, slightly less in women. Most of our iron is present in the hemoglobin molecule. It's stored as ferritin or hemosiderin in macrophages in the spleen, the bone marrow, and the liver. It's truly a carefully regulated system. So the amount of iron absorbed equals the amount of iron lost. There's no physiologic mechanism for iron excretion. So that's why we have to use chelators in order to remove iron in patients that have iron overload syndromes. So heme is the most bioavailable iron, and absorption of it's fairly constant. Inorganic iron depends on other dietary components to aid in its absorption. And the rate of absorption of our dietary iron is influenced by our total body iron stores at the time, our erythropoietic activity, our hemoglobin concentration, our blood oxygen content, and inflammatory cytokines. So hepcidin regulates iron absorption in our GI tract. It also regulates the release of iron from the macrophages by binding to ferroportin. Mutations in hereditary hemochromatosis protein, or HFE, can lead to a deficiency in the production of hepcidin and increased iron absorption. Hepcidin production is increased by up to 100-fold in inflammatory states, and that leads to a decreased absorption of iron from the GI tract and increased storage of iron in macrophages and hepatocytes. So there are two terms. There's hemosiderosis, which is a non-specific term which is used to describe a state of iron deposition in various body tissues or organs. And then there's hemachromatosis, which is a clinical expression of iron-induced injury in those affected body tissues. So HFE hemachromatosis, you guys may remember, is an autosomal recessive disorder. The C282Y abnormality causes the majority of cases in Caucasians. 15% of Caucasians are heterozygous for C282Y, and 5 out of 1,000 are homozygous. And homozygous C282Y abnormalities account for anywhere from 60 to 90% of clinical cases of hereditary hemochromatosis. So how do we diagnose hemochromatosis? We should look at the transferrin saturation, greater than 50% in males and greater than 45% in females, should prompt further evaluation. Ferritin is a good surrogate of total body iron stores. Molecular genotyping for the HFE gene. And then liver biopsy is still the gold standard for making the diagnosis of hemochromatosis, although there are MRIs now that we can do that have special coils that can help to relatively accurately try to assess the total iron deposition within the liver. So we hardly ever see these classic findings of hemochromatosis, skin bronzing, hepatomegaly, and diabetes, because on routine labs now, most people are getting picked up earlier. Non-specific symptoms of hemochromatosis can include fatigue, weakness, abdominal pain, arthralgias, elevations of liver-associated enzymes, and then, of course, deposition of iron in the pancreas can lead to pancreatic insufficiency and diabetes. Deposition in thyroid tissue can lead to hypothyroidism, and deposition in the testes can lead to hypogonadism. Cardiac abnormalities can occur, congestive heart failure and arrhythmias. Iron-induced liver disease, including fibrosis and cirrhosis, may develop if iron deposition goes untreated. And these patients have a 200 times increased risk of hepatocellular carcinoma if cirrhosis does develop. So how do we do this? Aggressively treat them before end organ damage occurs. Phlebotomy is the key therapeutic modality. It feels very archaic, but phlebotomy is removing blood until you get the ferritin down to a normal level, is the gold standard of therapy. So 1 unit of blood is going to remove about 200 to 250 milligrams of iron. We tend to do it weekly as long as the patient's tolerating it until their ferritin is between 20 and 50. We like to try to keep the ferritin below 50. Typically, lifelong maintenance is required, and the intervals of needing to do the phlebotomies vary from patient to patient. Somewhere between 2 and 4 months is the general time frame, with the goal to maintain the ferritin of 50 or less. They're at increased risk for infections with Vibrio vulnificus and Yersinia enterocolitica. And so patients who you're treating for hemochromatosis until you get their iron overload treated, They should be cautioned about consuming raw seafood, and they're also at increased risk for mucormycosis. There's a mutation in FPN1, which causes a disease called ferroportin. It's an autosomal dominant disorder, and it's characterized by elevated ferritins with a low or normal transferrin saturation. So these people don't have hemochromatosis, but oftentimes get mistaken for having it. And then secondary iron overload, we see this a lot in our heavily transfused patients, maybe patients that have sickle cell disease or other abnormalities. Certainly, if you can correct the underlying problem, that would be your goal. However, oftentimes we do have to chelate patients. So there's deferoxamine, which is a continuous subcutaneous infusion. It has some ocular and auditory toxicity potentials. There's defersirox, which is an oral chelator, which is not the easiest to tolerate, although most patients do pretty well. It can cause some nausea and vomiting. You have to monitor carefully because it is associated with agranulocytosis and elevations in creatinine and liver enzymes. Ocular and auditory toxicity has also been reported. And the goals of these chelators are also to decrease the serum ferritin to a normal range.